Hello and welcome to this session of the Center for Podiatric Education. In this session we're going to discuss the question of neuropathy in the elderly patient, age 65 and greater. As you well know, is the largest, most rapidly growing portion of our population, and increasingly we are seeing patients over the age of 65 who come to our offices with various manifestations of sensory, motor, or autonomic neuropathy. So I wanted to discuss a little bit some of the special considerations in the management of neuropathy in the older patient. Now, the impact of neuropathy depends on the symptomatology. If the patient has painful neuropathy, such as paresthesia or dysesthesia, cramping and so forth, this will impact on their quality of life. And when the symptoms are substantial enough, the patients are seeking relief of their symptoms to improve quality of life. Particularly in the diabetic patient, but not exclusively in the diabetic patient, we also have the issue of sensory loss and also autonomic neuropathy or motor neuropathy causing deformity. This, as you know, results in inability of the skin to tolerate pressure. It results in deformities at increased pressure. It results in injuries that are unperceived due to sensory loss and eventual potential for ulceration, Charcot joint disease, and amputation. So the impact of neuropathy can be quite significant depending on the symptomatology and signs with which the patient presents. It's important to remember that in dealing with neuropathy, regardless of etiology, but particularly in the patient with sensory neuropathy from diabetes and autonomic and motor neuropathy, a variety of symptoms can occur. And while classically we think about anesthesia and paresthesia and dysesthesia, frequently worse during the evening hours, occurring during the evening hours or at rest. It's also important to remember that we have instability in gait from, for example, sensory ataxia. We may have motor neuropathy with wasting of the musculature of the legs and feet with intrinsic minus foot type. We may have cramping. The patients may complain of sensations of pressure or hot or cold. And so we want to remember that the symptoms of neuropathy in our older patients go beyond just numbness, tingling, or burning in many circumstances, and may present as skin problems such as dry skin. It may present as a sensation of coldness from vasomotor instability. It may result in symptoms such as cramping. And we also want to remember that there can be an overlap between vascular disease and neuropathic symptoms, so that the presence of neuropathy does not exclude the coexistence of vascular disease, and the opposite is certainly true. So we don't want to make that mistake of getting fooled into classifying patients as being just neuropathic or just vascular. And the fact is that many patients can have manifestations of both. When I was a student at the Pennsylvania College of Podiatry, my professor was Henry Schuda, and he was a wonderful professor of neurology. It became obvious, at least to me early on, that neurology would be a big part of evaluating and treating patients with lower extremity pathology. Dr. Schuda used to break things down into three major issues. He said the first thing to do is to determine, is there a neurologic patient? Are the patient's signs and symptoms referable to a neurologic disorder, yes or no? And that's determined by history and examination and, of course, appropriate testing, or you certainly always have the option of referring the patients out for a neurologic examination. If the answer is yes, there is a neurologic problem, then the second question is, where is the problem? Is it central nervous system? Is it peripheral? Is it a myopathy? in determining at what level does that problem exist. So the second question, therefore, is number one, we have, is there a neurologic problem? Yes or no? Then you move on to say, where is the problem? At what level is that problem? And then the last thing we do is identify the specific nature of that problem. All too frequently, we want to rush ahead and put a name on that diagnosis before we establish firmly that there is a neurologic problem, and if so, at what level that problem exists. There's been some recent controversy regarding CMS looking at reducing podiatry codes and paying less for an E&M. And I think this is a perfect example of where we want to claim equivalence in education and training and diagnostic skills. So when we look at neuropathy in the elderly patient, you have basically two options. You could establish the presence of the neuropathy and do at least a limited workup equivalent to a primary care physician in trying to establish the etiology and then making an appropriate referral. Or you can simply say, yes, there's a neurologic problem, I'm not comfortable proceeding beyond saying there is a problem or perhaps at what level that problem exists, and then referring the patient appropriately. So it reminds me of the old Groucho Marx quote where someone asked him, are you a man or a mouse? And he said, well, put a cheese in front of me and you'll find out. And I think in the area of neuropathy, this certainly is a perfect example of that as to if you feel that your training is sufficient and equivalent, then you want to go ahead and do an appropriate questioning and take an appropriate history. You want to do an appropriate physical examination and order appropriate testing, and when appropriate, make a referral. When we get to the older patient, I think the big three are neuropathy, radiculopathy, and myelopathy. We want to remember that neuropathy is a disorder of the peripheral nervous system, and this can include both sensory and motor as well as peripheral autonomic neuropathic symptoms, period. A radiculopathy refers to disease of the spinal root. That is to say, typically it's going to be a nerve compression syndrome, and here again we may have both sensory or less commonly autonomic neuropathic changes, but certainly motor changes can play a role in the patient that has a radiculopathy, and we are going to look for evidence of weakness, in some instances spasticity, and then myelopathy, where you have a frank disease of the spinal cord itself. And these symptoms can include increasing presence of motor findings such as stiffness, perhaps incoordination, unsteady gait, and weakness. Now, with that said, we know that there are many patients who develop a neuropathy simply associated with aging, so that loss of the ankle reflex and loss of vibratory sensation are not uncommon in the elderly patients. And in the majority of these patients, or perhaps that's not fair, but let's say about half the time, we never do establish an etiology for that loss of vibratory sensation, and this is basically idiopathic or attributed to an autoimmune dysfunction associated with aging. As the listeners are probably well aware, if we were to select one disorder with which neuropathy is most commonly associated as we get older, it would certainly be diabetes. Other common disorders are listed here. One of the things I will do is look at the medications that the patients are taking, because frequently our older patients are taking a variety of medications, many of which can cause neuropathy as a side effect. We want to look at common vitamin deficiencies, particularly the B vitamins, and I would include in that vitamin D also. Perhaps the patient is exposed to some agent that is responsible or has been responsible in the past for causing a neuropathic disease. We want to remember that alcohol use is not exclusively a problem of younger individuals, and we do have quite a number of our elderly that continue to engage in heavy alcohol use, and this certainly can cause a neuropathy. And of course, we have neuropathy associated with HIV and drugs used to treat HIV disease. So when we take on the patient who presents with neuropathic signs and symptoms and establish in our own minds that the patient does probably have neuropathy, we then want to say to ourselves, do we want to ask appropriate questions? Certainly about alcohol use, smoking, exposure to toxins. Perhaps there is a compression syndrome, tarsal tunnel, common peroneal nerve, that type of thing. We always want to look at the possibility of concurrent vascular disease, as I mentioned, nutritional deficiencies, certainly metabolic disorders, again, diabetes and probably thyroid disease being the two most common. And we want to remember that neuropathy can be a manifestation of undiagnosed carcinomas or cancers in general, and that oftentimes we see peripheral neuropathy associated with chemotherapy. And there are things that we certainly can do to assist the patients in that regard. So looking at the etiology of peripheral neuropathy in our older patients, the question becomes, is there evidence of a nerve disease? Is there a peripheral neuropathy? And if so, do you want to engage in basic screening testing, which is not beyond the capabilities of the average podiatric physician, basic laboratory studies, or simply asking appropriate questions regarding the patient's overall health? And perhaps if you're uncomfortable proceeding any further, that's fine. You've done a great service just establishing the presence of a neuropathy through your history and confirmatory examination or laboratory studies, and then referring the patient back to the primary care doctor with confirmed presence of neuropathy and putting the responsibility for further workup on the primary care physician or the neurologist. Many of the patients that have a peripheral neuropathy as they get older do in fact have diabetes as the most common etiology, and there is also a neuropathy of impaired glucose tolerance. So that we know that patients that have A1Cs above normal, but not high enough to classify the patient as diabetic, or 2-hour postprandials that are again higher than normal, or glucose levels just random that are higher than normal but not high enough to classify as being specifically diabetic, that many of these patients have neuropathy. And I think most podiatrists know that neuropathy frequently precedes the diagnosis of diabetes, and it can do that for many years. So how often have we all seen that patient that presents with cramping or numbness or tingling or burning that turns out to be glucose intolerant or have in fact undiagnosed diabetes? So not infrequently I will see patients who are referred with lower extremity neurologic signs or symptoms, and they're told, well, it's not because I'm diabetic, because I'm quote pre-diabetic would be the term that most of these patients use. And I'll ask some questions about their family history, do an examination, and try to explain to these patients that while they are not diabetic, they have a neuropathy that's typical of diabetes, associated with impaired glucose tolerance, and frequently precedes the actual diagnosis of diabetes. And we know that with aging, we see increased incidence of neuropathy with impaired glucose tolerance, as well as in patients with diabetes themselves. One of the most important differential diagnoses that we can make as podiatric physicians, and there is no reason why you cannot do that, is that of spinal stenosis. Spinal stenosis is common in elderly patients. It is common in community-dwelling older patients. It can be responsible for lower extremity signs and symptoms, including legs and feet. And I think it's important to evaluate our patients for spinal stenosis. I do this on a regular basis. I include it in my notes. I think it helps the primary care physician to understand that we do have adequate training, that we are capable of answering the big question, which is, the patients in our office, are they in our office with a foot problem, or are they in the office with foot manifestations of a more global process? And when we identify signs and symptoms associated with spinal stenosis. Here again, an appropriate referral back to the primary care physician or to orthopedic or neurology spine service is oftentimes a wonderful service that we provide for our patients. So in the elderly, we know that spinal stenosis is common. Early on, the patients have claudication-like symptoms, so that these are patients that sound as though they have vascular disease. They say, when I walk a certain distance, I get cramping in my legs or leg, depending on the level of the stenosis and the manner in which they are compressed. And they will typically sit down rather than stop walking as typical claudicants, vascular claudicants do. And they will oftentimes relieve their symptoms by leaning forward. And this is a little bit different than the way the patient with arterial disease will describe their claudication, where they'll say, I just stop walking for a second, and then they reperfuse their legs, wash out their anaerobic products, and then proceed walking. So these patients will lean forward, they will sit down and lean forward. Later on, with chronicity, spinal stenosis will manifest with neuropathy-like symptoms. And so in evaluating patients who come to our office for evaluation of neuropathy-like symptoms, it is important to include evaluation or at least questioning of patients for the possibility of spinal stenosis and making an appropriate referral and making a note back to that primary care physician that you evaluated these patients for this problem. Now, one of the things we tend not to think about much is cervical myelopathy causing pseudoclaudication, but this is in fact not at all rare. And we could have compression of the spinal thalamic tract, meaning pain and temperature, corticospinal tract, which is important because some patients with cervical spine compression may present with lower extremity gait abnormality and hyperreflexia, or they may present with anterior horn cell compression with upper extremity weakness. So we want to remember that with spinal stenosis at the level of the cervical spine, there can be loss of deep touch and proprioception and vibratory perception, joint position sense, meaning posterior column function. Pain and temperature abnormalities may be noted because of compression or involvement of the lateral spinal thalamic tract and the anterior columns with loss of light touch. There are a number of easy tests one can do. One test that one can easily do is Lermet's sign, and just simply have the patient forward flex their head and neck down toward their chest and see if this exacerbates their symptoms. One can simply examine the patient and gait, and you'll notice that they will have a more broad-based, unstable gait. You can do Sperling's test, where you simply rotate the head toward the side that you think the compression exists on, and then plantar flex the head in that direction. There's no reason that you can't do these simple tests if the patient on questioning says, yes, I get some neck stiffness. If they're complaining of stiffness and weakness in their legs, if you perceive a wider gait that's somewhat unstable, you could ask the patient about clumsiness, and oftentimes because of the upper extremity root compression, they may in fact have some motor difficulties with their hands. And I always ask patients about bladder or bowel dysfunction, and I always include that in my neurologic examination if the focus of my examination that day is for a neurologic exam. Abnormalities in patella and Achilles reflexes, as I mentioned, if it's in the cervical spine, you get sometimes the equivalent of an upper motor neuron lesion, and you'll have hyperreflexive deep tendon reflexes. You may get lower extremity spasticity, clonus or hypertonicity, positive Babinski sign, and of course, as I mentioned, Lermet's sign easily elicited. One can do Hoffman reflex by flicking the fingers and looking for thumb response. This is somewhat equivalent to this is the upper extremity version, if you will, of the Babinski. So you could see that evaluating a patient for cervical spine disease affecting the lower extremities is not a difficult thing to do. And I'm not suggesting you're going to go ahead and order neck CTs or MRs or that type of thing, but you certainly are capable of examining the patient for evidence or questioning for symptoms of cervical spine compression syndrome, cervical cord disease that's affecting the lower extremity. In looking at these patients, you always want to remember that there's a difference between radiculopathy and myelopathy, which certainly is generally more serious. So with radiculopathies, we get sensory symptoms such as numbness or paresthesia or dysesthesia. You could ask about whether the patient has cervical spine pain, whether they have occipital pain, whether they get radiating symptoms or weakness in their arms. Radiculopathies tend to be unilateral because of the way in which discs tend to herniate, and upper extremity weakness. With a myelopathy, you tend to get bilateral weakness and neck pain. You get upper and lower paresthesias and dysesthesias, and you may have bladder or bowel dysfunction, again, with a positive Babinski, positive Hoffman sign. So in looking at evidence for a myelopathy or radiculopathy, spinal stenosis involving the cervical cord, these are tests that are easily done by you in the office, and they show that you are in fact capable of evaluating that patient for lower extremity manifestations of a more global process. We also not uncommonly see spinal stenosis in our elderly patients in the lumbar sacral area, and here again, this is not at all uncommon. We could ask patients about chronic low back pain and again a history of pseudoclaudication. So these patients get weakness or cramping when walking. They relieve it by sitting down, leaning forward, and this is typically the way in which they relieve their pain. And they get more of a musculoskeletal symptomatology as opposed to claudication of a vascular etiology where the patient again just stops walking. We can also have venous claudication, and in that situation we may see typically evidence of chronic venous insufficiency in that patient, and the patient describes a sense of fullness, of swelling, a sense that their legs want to explode from the swelling. With spinal stenosis of the lumbar spine, your neurologic examination may be normal. You may detect some slight weakness if you take the time to do manual muscle testing. And if you're not doing manual muscle testing, then you're not doing a complete neurologic examination. People with lumbar stenosis, lumbar spine stenosis, tend to have a posture leaning forward because this relieves pressure on the disc and on their spinal roots. They tend to have a bit of hip and knee flexion. They tend to have tight hamstrings. They may or may not have sensory findings, and again, you may see some gait abnormalities. In testing for lumbosacral disease, straight leg raising test is easy enough to perform. I just lay the patient back in the podiatry chair, and you elevate their leg, flexing their hip, extending their knee, dorsiflexing their foot and toes. This places maximal strain on the sciatic nerve, and if they complain of neurologic-like symptoms at less than 60 degrees elevation, then you have reason to believe or suspect that they may in fact have lumbar spinal stenosis. Again, these are simple tests to conduct in the office, and you can have the patient just walk briskly up and down the hall and keep on walking until you elicit their symptoms. And you'll find that patients with spinal stenosis will then tend to lean forward to relieve their symptoms. At first, they will describe pain and then cramping and motor symptoms. Or you could simply do the lumbar extension test and have the patient extend their back, as you see illustrated here, have them hold that for 30 to 60 seconds, and if they have lumbar stenosis, frequently they will elicit or create symptoms by this simple maneuver. What about red flags for serious low back pain? They're listed here, but when patients say that they have pain in their back at night, that's of a concern. If they've had recent bacterial infections elsewhere, perhaps you're treating them for a foot infection. If there's a history of intravenous drug use or any scenario where you think they may have an infection in the low back, if they're having persistent leg pain, if there's bladder or bowel dysfunction, that warrants immediate referral back to the primary care physician or to the emergency department. Obviously, major trauma. The patient that has low back pain, lower extremity symptoms, and has a history of being treated for any type of cancer, obviously that's an issue. If they've had fever, weight loss, again, we have to be concerned about infection and malignancy. So there are a number of scenarios in which we can ask. We could do a basic evaluation and refer that patient out. Now, specifically with reference to peripheral neuropathy, we want to remember that many peripheral neuropathies start as small fiber and then progress to large fiber disease. So the small fibers would include the nerves that innervate the sweat glands, that regulate the little teeny blood vessels in terms of dilation and contracture, and that includes the veins, by the way. And then we have effects of the neuropathy on cold and warm perception. And then we get into the larger nerves, the more myelinated nerves, and there we get into affectations of joint position sense, vibratory perception, light touch, so more involvement of the posterior columns, the anterior columns. It's important to remember that typically small fiber neuropathy precedes large fiber neuropathy, sometimes for years. And there's a difference in the clinical manifestations, both in terms of symptoms as well as signs. Now, in looking at the diabetic patient as an example, and this is what you'd see if you came to my office on any countertop, so that all my rooms, if you look at the countertop, this is what you'd see for basic screening. And my basic screening will include a Doppler, handheld Doppler. I also have printing Dopplers when I'm doing more of, or have more vascular concerns. But you could use a 128 tuning fork, check for pinprick, 10-gram filament perception. You want to check ankle reflexes. And I also use the tuning fork to check for temperature perception. I just put it on the pulp of their big toes and I ask the patient, is this warm or is this cold? And you could see that this has been looked at as a basic screening, and this will enable you to detect neuropathy with about an 87% sensitivity. So this is a low-tech, high-touch examination, which is very, very helpful. And again, there's no reason why anyone practicing in a primary care podiatric setting is not capable of doing this basic evaluation. And then we look at the patient in terms of their basic modified neuropathy disability score. Do they have an Achilles tendon reflex or not? How are they on vibratory perception with a 128 tuning fork? How are they on temperature perception and on pinprick? So this is a rather simple screening that enables you to determine with some degree of reasonable sensitivity as to whether a neuropathy is present or not. There are many alternatives to the standard examination, which again I would argue is primarily going to be high touch and low tech. But you certainly can utilize a variety of technologies. There are many technologies available that can be used for evaluating and quantifying the extent of neuropathy. I would say that probably the EMG and nerve conduction studies and PSSD would be the most common, but certainly there are other means by which one can screen and quantitate patients for their neuropathy. I think most of us realize that our neurology colleagues and physiatry colleagues tend to go first to nerve conduction velocities, but you want to keep in mind that this is a test primarily of large fiber neuropathy. And oftentimes small fiber neuropathy is present, and precedes large fiber neuropathy. So these are the patients that come to our office and tell us that they have various symptoms or signs which in our minds are highly suggestive of a peripheral neuropathy, but they've had a nerve conduction study which was, quote, normal. So and the problem is it doesn't eliminate small fiber neuropathy. And we also want to remember that some abnormalities in nerve conduction studies can be present in an otherwise normal older patient. And that is why when all is said and done, although we certainly want to utilize electrodiagnostic studies, I order these several times weekly on various patients, there's still no substitute for a good history and physical examination. We've heard much about epidermal nerve fiber density testing. This is something that can easily be done by any podiatric physician. It is a 3 millimeter punch. This has to be sent to a laboratory that does epidermal nerve fiber density testing, and this is a test that will detect the presence, as the name implies, of small fiber neuropathy even in the presence of a normal examination or with an abnormal history, or in patients that have normal nerve conduction studies. And because we know that small fiber neuropathy can precede large fiber neuropathy by years, this means that there are a number of patients who have a normal electrodiagnostic test who in fact will show confirmatory changes on epidermal nerve fiber density testing that they do in fact have a neuropathy which is present, which otherwise would have gone undetected. This is a test that's easily done in the office. It's done under local anesthesia. You want to do the test typically where we have normals. I will typically do the test about 10 centimeters above the lateral malleolus, posterior to the peroneal tendons, anterior to the Achilles tendon. And the samples are sent to the appropriate laboratory. They will then utilize a stain that makes the nerves visible. That stain is coupled to an antibody against an antigen on the surface of the nerves so that we literally can outline the nerves and count the number of nerves that are innervating the skin. And as you'd expect, with the presence of small fiber neuropathy, initially you'll see abnormalities in the nerves themselves, and then later on you will see the decreased numbers of nerves. And these normals have been well established now for quite some time, and the test is quite reliable for detecting small fiber neuropathy early on. Now, we also want to remember that the small fibers include the autonomic nerves. So we may have patients that have vasomotor changes. They may say, my feet feel cold even though their feet are warm, and they have good pulses, but they have delayed capillary filling. They may have dry skin, and they may complain of numbness and paresthesia. So we do have patients that have autonomic neuropathy early on. And that can be detected even earlier than normal changes with epidermal nerve fiber density testing by sweat gland innervation testing. So here again, it's a 3 millimeter punch biopsy. It is basically an equivalent test to the test done for epidermal nerve fiber density testing. The difference is here we're looking at the innervation of the sweat glands. So to your right is a normal sweat gland with its normal innervation. To your left, a sweat gland that has lost innervation because of small fiber neuropathy, specifically loss of innervation to the sweat glands. That is to say, the patient has autonomic neuropathic changes. This is a simple test, easily done in the office setting under local anesthesia. So the general protocol is, again, consider the etiology. Is there a neurologic problem? Where is the problem? And lastly, what is the problem? Always consider the possibility of peripheral arterial disease even when you've made the diagnosis of neuropathy in the older patient. We keep in mind that glucose intolerance and diabetes are very common causes of neuropathy in the elderly patient. You want to make sure that you rule out entrapment neuropathies, not only just tarsal tunnel and popliteal and common peroneal nerve, but make sure you're looking for cervical spine and lumbar spine compression syndromes, look at the drugs that they're taking and whether or not that can be causing a problem. A very common example is metformin. We know that in diabetic patients taking metformin, we have an increased incidence of neuropathy, and we have an increased depth of neuropathy because of the effects of metformin on certain B vitamins. And we know that simple supplementation of the patient's diet with B12, L-methylfolate, and that alone will be sufficient in many patients to reverse the neuropathy caused by the metformin. And then we want to decide how we want to treat these patients, symptomatic and improve nerve function. So the treatment for neuropathy, and my estimate, number one, is education. We need to talk to the patients, explain what's going on, make sure that they have a full understanding of the neuropathy symptoms and the causes of those symptoms. When we use drugs such as gabapentin or other anti-seizure medications, and when we use antidepressants such as tricyclic antidepressants or serotonin, norepinephrine reuptake inhibitors, or when we utilize opioid analgesics, or most of the medicines that are used to treat neuropathy, we want to keep in mind that in older patients we want to start low and slowly go high, so that dosage titration is important. And I let patients know that I'm going to start you on a lower dose because many of these medicines can make you drowsy or dizzy or have anticholinergic side effects, this type of thing. And so I'll start the patients at a lower dose. They need to understand that they may not have relief of symptoms early on. It may take some time to totally get them where they need to be. I tell them that they have to be careful initially taking these medications, and that we'll titrate them and see them on multiple visits to see how they're doing, and slowly titrate their dose until hopefully we're able to resolve their symptoms. Each patient is different. Some patients will respond to just one medication. Typically, patients will require 2 medications. Some patients, the treatment will be aimed at just relief of symptoms. In other patients, we will try to relieve their symptoms and improve nerve function. There may be a role for decompression surgery in some patients. In many patients, we will combine both oral and topical therapies, which is a wonderful way to go, in my opinion, because the topical therapies, when they are helpful, allow us to reduce the dosage of the oral medications and therefore decrease the frequency or intensity of the side effects. So combination therapy is something we do a lot. The pharmacologic management of neuropathy, again, typically more than one drug is going to be involved. Antidepressants have long been a mainstay of treating peripheral neuropathy. Most commonly, we will use drugs like amitriptyline or nortriptyline, again, starting at a lower dose. If the patient's symptoms are exclusively during the evening hours, then we just dose the patient at night to get them a restful or a restorative night's sleep. Obviously, the symptoms during the day would require daytime dosing, so we get into BID or TID dosing, bring them along slowly. When you engage to treat patients pharmacologically for peripheral neuropathy, there's also an obligation to monitor the patients not only for response to treatment, but for the absence of side effects, so that when I see patients that I'm treating for neuropathy, I will document whether they're having any swelling, tachycardia or palpitations, chest pain, dry eye, dry mouth, difficulty urinating. There are certain responsibilities that go along with utilizing these medications, knowing about the potential for adverse sequelae. And again, here in our elderly population, because of polypharmacy, we have to be really careful as to making sure that we don't have any significant potential drug interactions with the antidepressants. Both tricyclic antidepressants and serotonin norepinephrine reuptake inhibitors have been described for the use of peripheral neuropathy. Anticonvulsants have been around quite some time. Probably the 2 best known for the treatment of neuropathy are gabapentin, as also pregabalin, Lyrica. And here again, there's a tendency towards drowsiness and other significant side effects. There's no reason why you cannot familiarize yourself with these agents, the side effects, drug interactions, and use them appropriately. We used to hear that neuropathic pain did not respond to standard pain medications and that we needed to use so-called adjuvant analgesics. We know that's not the case, and there is a role in some patients for opioid analgesics if they're having significant symptoms. We have certain drugs that are bridging drugs, such as tapentadol, Nucynta, which is also helpful in treating many patients with a neuropathy. Oftentimes we can supplement the oral therapy or even substitute oral therapy with topical therapies. I'll discuss some of those in a moment. Physical therapy has been shown to be helpful, and other things can be tried. For example, transcutaneous nerve stimulators can be utilized, and in severe cases one can refer to pain management for consideration of spinal cord stimulators. There are also supplements and vitamins that have been shown to be helpful in treating symptomatic neuropathy. This would include agents such as alpha-lipoic acid, carnitine, L-methylfolate, methylcobalamin, and pyridoxal 5-phosphate, and vitamin D. In utilizing some of the more common agents that are utilized, amitriptyline, if the patient is having primarily nighttime symptoms, then we'll go ahead and start them at a low dose, typically 10 milligrams an hour before they go to bed, and slowly titrate the dose up. I'll generally see the patients back in 1 month, see how they're doing, either keep them at the dose that we've prescribed or gradually titrate the dose up. As far as gabapentin goes, we again start them at a low dose, typically 100 milligrams, either HS or TID if they're having continuing symptoms. Have the patient back in a month or so, and then gradually again titrate the dose up. Pregabalin, a bit more expensive. You have to watch patients for swelling, which is not at all an uncommon side effect with pregabalin. And here again, we will slowly increase the dose as required. There are quite a number of medications that can be utilized for the treatment of neuropathy. Tramadol is a drug that seems to be helpful in some patients for the treatment of their neuropathy. Here again, we have to be careful because we are dealing with older patients who are more susceptible to side effects of these medications, and we have to watch more carefully for the potential of drug interactions. There are also topical agents such as lidocaine and capsaicin that can be helpful. In addition to traditional analgesics or adjunctive analgesics, if you will, the antidepressants, the anti-seizure medications, the opioids, there's also a role for alternative therapies here. If you think alcohol is an issue, or in particular patients, thiamine supplementation may be important, particularly in patients taking metformin, but also the general population. Deficiency in B12 is not at all uncommon, and sometimes simple vitamin B12 therapy or combination of L-methylfolate, B6, B12 therapy is sufficient to substantially impact the patient's symptoms. And you can start with these therapies, and there's going to be a percentage of patients who are going to respond, or you could add them to existing therapies depending on how the patient's doing. There's alpha-lipoic acid, there's L-carnitine, and topical agents. With regard to small fiber neuropathy, again, just to remind you that while we're treating the symptoms, sometimes the cause, if it's something specific like B12, it is important to realize that if the patient is not responding appropriately, it may be because there is an etiology for that small fiber neuropathy that needs to be addressed. Remembering that vascular disease and neuropathy can coexist in the same patients. They could give you the same type of symptoms, and therefore, again, it's always important to reconsider the impact of vascular disease. And there's no better example of that than the diabetic patient who initially develops metabolic problems with the nerve, and then we have superimposed vascular pathology in addition. B12 deficiency is common in the patients with diabetes, particularly those taking metformin. Many times the patients will have a seemingly normal B12 level but have a functional deficiency, so that if we were to order blood work for markers of B12 deficiency, such as methylmalonic acid, we find that while the patient has a, quote, normal B12 level, they functionally have a B12 deficiency, and this is not at all rare. The majority of these patients will have neuropathic symptoms and will respond to replacement of cobalamin. So in looking at the treatment of neuropathy in our patients, again, we want to improve quality of life, improve physical functioning, and we want to hopefully reduce the progression of that neuropathy. Alpha-lipoic acid has been shown to be very helpful in the treatment of neuropathy. It's given at an initial dose of 600 milligrams daily. You can go as high as 1,800 milligrams daily, and there's really a good deal of literature around to suggest that in patients with neuropathy, and in particular diabetic neuropathy, alpha-lipoic acid is helpful. And this is certainly something that any podiatric physician can prescribe. Getting back to vitamin B for a second, the B deficiencies rather, we know that these deficiencies, again, are common in the elderly, they're common in the diabetic patients, and combination therapies with L-methylfolate, B6, B12 have been shown to be helpful. Vitamin D has been shown to be associated with neuropathy, and particularly in Hispanic Americans and Black Americans with neuropathy. We know that vitamin D deficiency is not at all uncommon, and while we tend to think about vitamin D in terms of bone health, it is an important part of neuropathy evaluation, and there are patients who will respond to simple vitamin D supplementation. Acetyl L-carnitine has been shown to be helpful in the treatment of many patients with neuropathy. You have to give an adequate dose of between 2 and 4 grams per day. It seems to be helpful not only for sensory symptoms but also for motor neuropathy. And this, again, is a simple thing that can be prescribed by the podiatric physician. Not much in the way of adverse sequelae, and many patients will do well with that. The majority of patients, or studies rather, seem to imply that more than one drug is required for the treatment of neuropathy, so that frequently we have to combine therapies. We may see a patient who, for example, is being treated by their primary or neurologist for peripheral neuropathy, diabetic or otherwise, and they may have substantial but not total resolution of their symptoms, and by adding a supplement or vitamin or utilizing some additional topical therapy, we may get that patient to a point where they do in fact have substantial resolution of their symptoms. I want to say a few words about topical therapy, in particular compounded analgesics. There are a number of over-the-counter pain creams that can be used. Capsaicin has been a mainstay of treating neuropathy for a long time. We have topical lidocaine and, of course, compounded medications. Now, the reasons that I like compounded medications are several. Number one is it enables me to, in some patients, totally resolve their symptoms of neuropathy without worrying about side effects. So there is some systemic absorption, as much as 15% can occur, and you get the occasional patient that does get a contact allergy to any topical. But in general, these things are quite safe. They're certainly not perfect, but in general, they're quite safe. They are effective in many patients, and as a first step, I explain to patients, look, one of the advantages of a topical is that I can give you multiple drugs in one compound, and this is the reason why in front of you, and that is that we know that pain involves multiple neuroconductors, multiple receptor sites. That is why different drugs are effective in different patients, because We have different receptor sites, activating sites, blocking sites for pain conduction, and that is why, depending on one individual patient, one drug may be effective for a patient and not for another. When I give a compounded medication, I can give a medication that acts at multiple receptor sites, multiple conduction sites, acts on multiple neuroconductors, so if one medication doesn't work, another one will. And the reason I give these lengthy explanations to the patients is that in general, compounded medications are going to be more expensive than the same medications given orally. So I tell the patient, look, these drugs have side effects. They slow down all the nerves, not just the nerves in your feet. And so even though we're giving this, it's going to be a little bit more expensive. It is safer, it's effective, so that there are good reasons to invest in this initially, see how you do. If it's effective, we'll maintain the compounding cream. If not, we'll flip you over to a different medication. It's also important when questioning patients when they come back, whether it's oral or topical, as to how they're doing. Because patients may initially say, well, I still have burning, or I still have tingling, or I still have shooting pains. But then when you question them, you find out that in fact the drugs are effective. They are reducing the frequency and intensity of their symptoms. It just may not be 100%, and that is why combination therapies are quite helpful. So in looking at compounded pain creams for the treatment of neuropathy, particularly in the elderly patients, I will want to see various combinations of gabapentin and lidocaine. Clonidine for sure is excellent for peripheral neuropathies. Ketamine, if I need some vasodilation, then perhaps some nifedipine or pentoxifylline. So you could compound up any number of medications that you think are appropriate, and this is helpful in a lot of patients, and it is, of course, symptomatic treatment without worrying too much about side effects. There are a number of other topical agents that can be utilized and may be successful, such as capsaicin, lidocaine patches or creams, eutectic mixtures of local anesthesia. There are a number of these, or just having the patient start with some over-the-counter pre-made arthritis creams or pain creams. There are a number of other technologies that can be utilized in the older patient for the treatment of neuropathy, such as spinal cord stimulators, relaxation techniques, hypnosis, acupuncture, biofeedback, and certainly transcutaneous nerve stimulators. So in summary, this is an issue that we confront increasingly as podiatric physicians. It is something with which we could play a role. And the role you play depends on how far you want to go and how much of a doctor you want to be. The critical thing to do is to evaluate the patient for any problem and say yes or no. Is this a foot problem, or is it a foot manifestation of a more global process? I don't know how you answer that question without a proper history and proper physical examination. Now, once you've determined that there is a neurologic problem, and you've determined the level of that problem, and lastly, you may or may not want to go so far as to determine the etiology and therefore treatment of that problem, you play a role in many ways. One would be proper referral of the patient, and you've done a yeoman's job there. You've made a proper diagnosis, you said here's why your foot's a problem, and you've made an appropriate referral. Or you could play a primary or secondary role in treatment. And there are many things you can do if you are uncomfortable with tricyclic antidepressants and anti-seizure medications or prescribing opioid or opioid-like drugs. You certainly can utilize topical therapies, which are helpful in a number of patients. You can utilize vitamin and supplemental therapies, which are helpful in a number of patients, and improve quality of life in many patients. So hopefully you found this an interesting discussion regarding the treatment of neuropathy in the geriatric patient. Thank you.